Now that we've established that we have acceptable regimens or regimens that have activity in the first line, the question is what regimens, what options do we have for second line? For many, many years, we had a suboptimal first line regimen and no options in the second line. And then we had gemcitabine, nab-paclitaxel, and FOLFIRINOX that were made available to us in the first line. And again, we still suffered from the lack of standard in the second line. Many oncologists used FOLFOX, some used FOLFIRI, some used 5-FU, and others just, if there wasn't trial, patients were sent essentially to best supportive care and palliative care. Recently, nanoliposomal irinotecan MM398 and 5-FU in a study called Napoli-1 showed superiority versus 5-FU alone. There was another arm with MM398, so the nanoliposomal irinotecan alone, which did not show more activity than 5-FU. So the standard has shifted from essentially 5-FU or no therapy to 5-FU plus MM398. So that would be today our gold standard, the standard of care in treating patients who failed first line gemcitabine-based regimen in the first line with metastatic pancreas cancer. The question that remains is essentially we have a study from the mid-2000s with oxaliplatin and 5-FU OFF. That's a CONCO study out of Germany, and essentially that study suggested an improvement of OFF versus 5-FU. And that led actually to a lot of US oncologists using FOLFOX in the United States. Then comes another study from Canada, and 2 years ago was presented actually, showing that FOLFOX6 is no better than 5-FU. In fact, the survival was even worse with FOLFOX than with 5-FU. And there may have been reasons for that. But at this point of time, oxaliplatin does not seem to have the same level of evidence than 5-FU MM398. And therefore, oxaliplatin and oxaliplatin's activity remains with a question mark in pancreas cancer. Another question that always comes about is, how about FOLFIRI? Since MM398 is a nanoliposomal formulation of irinotecan, how about the cheaper version, irinotecan? Unfortunately, there hasn't been much done with FOLFIRI. So there are theoretical advantages for the nanoliposomal formulation of irinotecan, but clinically we do not have that data in pancreas cancer. We do not have data about FOLFIRI, and therefore I think unfortunately at this point of time it is difficult to recommend FOLFIRI as an option, and because of the confusing data with oxaliplatin, I would not recommend oxaliplatin in the second line. And I think the standard would be 5-FU MM398 in patients who failed gemcitabine and nab-paclitaxel or gemcitabine formulations in the first line. Then there is a small group of patients in the United States that receives FOLFIRINOX in the first line. That's about 10-15% of the patients, and shrinking actually. Those patients would not receive in the second line 5-FU MM398. There's a little bit more difficult space because we don't really have a lot of options that were studied in this line. So some folks would use gemcitabine single agent, which doesn't have much activity, or gemcitabine nab-paclitaxel, but the concern would be the overlapping neurotoxicity. FOLFIRINOX has neurotoxicity, gemabraxane can compound to that. So I think a more rational approach, which goes back to another part of the discussion, is to actually think rationally about a 2-drug combination followed by a 2-drug combination. So a sequential gemcitabine nab-paclitaxel followed by 5-FU MM398 would be the most rational sequence, I think, at this point of time, treating most patients, I'd say, with pancreas cancer. So in terms of selecting for patients who go on gemcitabine-based regimens versus 5-FU-based regimens, in the first line, the question is, of course, FOLFIRINOX versus gemcitabine and nab-paclitaxel. FOLFIRINOX is a 3-drug regimen more aggressive, more toxicities, gemcitabine, nab-paclitaxel, is essentially active, but probably a lesser response rate, but overall seems to be quite effective. And the question is, how do you pick one versus the other, the gemcitabine versus the 5-FU based regimen? So I think the answer comes from twofold. One, 3-drug regimens are more toxic in a disease at stage 4 where you're mostly looking for palliation. It doesn't make as much sense, I think. On the other hand, the second fold for this is that we do have an active regimen in the second line, and gemcitabine, or in patients who failed gemcitabine-based regimens, and that's 5-FU and MM398. And so using a sequential approach with the 2 drugs followed by 2 drugs would make more sense. So I think in absolute terms, if we actually take away the second-line option, and when you have to choose between the 5-FU based regimen, FOLFIRINOX, and gemcitabine nab-paclitaxel, which is gemcitabine based regimen, then a patient who's very young, who has an excellent performance status, may go on FOLFIRINOX, whereby all others would go on gemcitabine nab-paclitaxel unless they have a very poor performance status. Then treatment is not an option. However, today, with the presence of the second-line regimen that has activity, one would question, again, the all-kitchen sink approach with throwing all these 3 drugs together versus adopting a more sequential approach.